I think, I think what's been really impressive across the last few days is all the ways that we're trying to get immunotherapy to work for prostate cancer. We've heard about NK cells, T cell engagers, trikes, CAR T cells. So I'm going to talk about Tregs a little bit and some of the efforts we've been working on to deplete Tregs within the tumor microenvironment. And I think this point has really been made across several sessions that the neoadjuvant approach has several advantages biologically. So the first is you have the tumor infiltrating lymphocytes present. There's abundance of tumor antigen when you give these drugs. Probably the presence of tumor draining lymph nodes is important. And really, it's this idea of can we eradicate any residual disease or micrometastatic disease that I think is really important to consider. And then on the clinical side, we know that although prostate cancer is highly treatable in many contexts, many of these patients will recur. And so can we leverage therapies that really do focus on elimination of disease? And then I think biologically, the rich biological data we get from these specimens at the time of surgery is quite precious material. But then, of course, we know the challenges, regulatory endpoints, and the sort of typical way that drug development is done. And so yesterday, or actually 2 days ago, I spoke about anti-PD-1 drugs and immune checkpoints, and they haven't worked in prostate cancer. And I think that is generally true. But actually, if you'll look back at one of the original phase 3 studies, the 043 study of IPI, although it was a negative study on longer term follow-up, there actually was a statistical benefit of IPI in the phase 3. And we know that the response rate of IPI compared to anti-PD-1 is higher in the order of maybe 15-20% instead of 0 to 5%. And so, based on really preclinical work that was done in Chuck Drake's lab, looking in the MICAP model, castrating mice, they go on to develop castration resistance, and looking at those time points, both pre-castration, 7 days post-castration, and then at the time of castration resistance, if we look at the Treg population post-ADT, we see an expansion and then a contraction of that population. And when you treat these mice with a non-depleting CTLA-4 antibody versus a depleting CTLA-4 antibody, we see improved survival in the mice. And we've also looked in our human specimens and shown that there's actually an increase within 14 days of FOXP3 positive Tregs after degarelix administration. And so that really led to the hypothesis, right? So that IPI alone is a blocking antibody, but not such a good depleting antibody. And if we remove a fucose group from the FC portion of the antibody, you can actually hopefully enhance its FC function and depleting function. And so there's a number of drugs that are out there that work this way. We worked with the son of IPI, BMS 986218 in this context. And so just as a reminder, again, we spoke about this a couple of days ago, is antibodies have, of course, their Fab portion, which binds to antigen, as well as the FC portion, which has really a lot of different functions. It binds to FC receptors. There are activating receptors, inhibitory receptors, and these mediate ADCC, ADCP, and then, as we talked about in the context of CD40, they play an important role in cross-linking. And so the design, we did a window of opportunity study, a small study looking at men with high-risk localized prostate cancer, randomized to we actually treated the first 4 patients with a combination of the anti-CTLA-4 antibody plus hormonal therapy, and compare that to ADT alone. And then concurrently, so patients who did not go on study, who went to radical prostatectomy, we collected their tissue as a sort of matched control along the way. And so it was really a very short interval of treatment. We gave dose 1 of the anti-CTLA-4 drug. A week later, we gave hormonal therapy, and then a week later, a second dose, and then a week later, they went to surgery. So they got a total of really only 3 weeks of therapy before radical prostatectomy. And so the primary endpoint of the study was really tolerability and feasibility of using this immunotherapy approach in this setting. And so it was well tolerated. We really only saw one grade 3 asymptomatic lipase elevation, which had really no clinical significance for the patient. One grade 2 colitis, which didn't interfere with surgery or surgical outcomes. And, when we looked at our population, we actually had a very, at least by NCCN, risk stratification, a very high risk population. And so this is just looking at the sort of some of the clinical data. You can't really compare these arms, but all the patients, the recurrence rate was quite low across the board, but it gave us an opportunity to really understand drug MOA. And so much of that work was done by really a collaborative effort with Pat McCann, who's one of our technicians in the group, Casey Yeager, who was a postdoc at the time and is now at Mayo, Arizona as an assistant professor there. And then on the bioinformatics team with Andrea Califano and Alex. And so we did sort of a combination of CyTOF with a 35 marker panel, as well as single cell RNA-seq and some spatial profiling. And so I'll make sort of just a few points about what we found. The first is that we looked at Tregs based on our hypothesis. And so if you compare treated to ADT treated to the combination, we see an increase in the Tregs as expected with ADT, and then with the depleting antibody, a relative depletion, although not a complete depletion of Tregs. So perhaps the drug is not fully depleting Tregs. And I don't have time to talk about it, but there's some phenotypic differences that we think are important in the remaining Tregs. The second point is that Tregs do, in the context of the treatment, do predict recurrence. This is actually in contrast to large data sets where Tregs do not seem to predict recurrence risk in larger population studies. So the last sort of biology that I'll show you is that we think, again, that the mechanism of action is through the Fc binding to CD16 or the 3A receptor. And so we were able to look at our single cell data, show look at CD16 positive TAMs. And if we look at the correlation with Tregs and CD16 positive TAMs, we saw a inverse correlation with the combination as opposed to with ADT alone, where there was no difference. And then the last point I'll make is that we did see that dendritic cells seem to predict recurrence in our study. And so our model is really that these Fc-enhanced anti-CTLA-4 antibodies may actually bridge T cells and the antigen-presenting cells, resulting in better priming, and then also that the depth of myeloid depletion, depth of Treg depletion really depends on these CD16 positive myeloid cells within the tumor microenvironment. But can we enhance those through dendritic cell manipulation? I spoke about that a couple of days ago.